Thermo Fisher Scientific presents The Next Step, a diagnostic testing series. Created to help physicians appreciate the nuances of laboratory testing, Thermo Fisher Scientific has developed a series of short videos in the Next Step series by noted experts, focusing on demystifying laboratory testing in common, but sometimes difficult to diagnose autoimmune diseases, such as rheumatoid arthritis, systemic lupus erythematosus, and celiac disease. Your host will be Dr. Anagh Vora, the U.S. Medical Director Autoimmunity at Thermo Fisher Scientific. Dr. Vora, in his current role, directs institutional and physician education. He has lectured extensively at medical schools in the U.S. and Europe, including Harvard, Stanford, and the Karolinska Institute on the application and appropriate utilization of laboratory testing.
I'm Anagh Vora, and as a laboratory physician and clinical pathologist, I understand the difficulty that many of us face in navigating the complexity of laboratory testing, especially with newer technologies such as next-generation sequencing or the latest clinical biomarkers. But if not ordered in the right sequence or used in the correct clinical scenario, even older tests can be confusing.
Clinical implications of laboratory testing. Why specificity matters.
To understand the role of laboratory testing, it is first important to address common concerns many of us have around testing. This includes the increased cost of laboratory testing, especially with the use of newer genetic tests or the possibility of over-testing and inappropriate testing. Finally, what are the clinical implications of laboratory parameters that are poorly understood, such as sensitivity, specificity, negative predictive value, and positive predictive value? Most of us have certainly heard of these terms numerous times. Some of us might have even calculated them. But do we always understand their clinical implications? Especially when there are seemingly trivial differences between different laboratory tests. Let's look at this in more detail.
Are we over-testing?
It is often stated that we are ordering too many tests. However, based on a recent meta-analysis from Harvard spanning 15 years, we are not ordering enough of the correct tests nearly half of the time. This issue is not isolated to the US, but a trend that affects physicians worldwide.
What about additional costs?
We are constantly reminded about the appropriate utilization of resources, especially in avoiding unnecessary testing. In reality, lab testing, including genetic testing, represents a very small percentage of the total healthcare expenses. Laboratory testing represents around 2% of total healthcare costs, yet contributes to 70% of the medical decision process. Consequently, ordering the appropriate laboratory tests are not only cost-effective, but provide better care for our patients. As the ordering physician, we are ultimately responsible for understanding the appropriateness and limitations of the tests we choose, not only around the possibility of false positives and negatives, but the resulting clinical consequences to our patient from our choices.
Genetic testing for breast cancer risk.
1 in 8 women will get breast cancer in their lifetime. Naturally, many women and their physicians are concerned about testing for this entity. The presence of BRCA1 and 2 mutations have been linked to earlier and more aggressive forms of breast cancer, as well as ovarian and fallopian tube cancer. Testing for this mutation in all women sounds like a good idea and has been advocated by a few researchers. Whether at-risk patients can be identified earlier based on mutation status. In fact, 92% of primary care doctors surveyed would refer patients for BRCA testing irrespective of patient clinical characteristics or even when they did not meet recommended guidelines for genetic testing. However, when this testing model was analyzed without consideration to family or personal risk factors or clinical signs and symptoms, researchers at UCLA were able to show that for 99.75% of women, this testing would not be helpful. In fact, not only is BRCA testing inappropriate in the general population, since the prevalence of these mutations are rare, 1 in 400 or 1/4 of 1%, but a negative genetic test does not confer any gain in life expectancy or eliminate the need for regular mammograms. In addition, such testing may provide a false sense of reassurance that they will not develop breast cancer in the future. It is apparent that indiscriminate testing to rule out even serious conditions not only wastes valuable resources, but may cause real harm to our patients.
Why specificity matters.
Sensitivity and specificity are almost always mentioned in tandem, but many clinicians simply focus on sensitivity when they look at laboratory testing, because they mistakenly equate a high sensitivity with high accuracy.
Sensitivity versus specificity, which is important?
So which parameter is more important? Is it sensitivity or specificity? Obviously, both are important, and one should always choose the test with the best combination. However, the decision also depends on why we are ordering the test in the first place, as well as the prevalence of disease, like we demonstrated with the BRCA testing earlier. When trying to diagnose or rule in clinically significant diseases, like cancer or incurable systemic autoimmune diseases such as RA or SLE, specificity plays a greater role in identifying the correct at-risk patients. Laboratory tests with high specificity and/or PPV, or how often the patient has the disease when the test is positive, decrease the potential for false positives, minimize inappropriate additional testing required, and the dangers of unnecessary and potentially toxic treatments. Let's look at examples of the role of specificity in both autoimmune and allergy testing, and how choosing the right test improves patient care.
The importance of specificity in autoimmune diseases, reducing false positives.
Systemic autoimmune diseases are common disorders in subspecialty clinics. However, in the general population, diseases such as RA, SLE, and even celiac disease have a prevalence of around 1%. Consequently, it is important for us to choose tests that optimize specificity and positive predictive value when we want to confirm a diagnosis or refer the patient for further treatment. In contrast, if we choose a test which optimizes sensitivity rather than specificity, then we run the risk of labeling patients positive when they don't have disease, or refer patients inappropriately, leading to unnecessary testing and potentially dangerous treatments. For example, when ordering CCP in patients for rheumatoid arthritis, if we choose CCP 3.1 instead of the more specific CCP 2, this can lead to a 7-fold increase in the number of false positives in our test population. How do you know which CCP test you are ordering? Ask the pathologist or laboratory which type of CCP they run, since this directly affects patient care. Remember that up to 7 times as many patients will be falsely labeled suspicious for an incurable autoimmune disease, refer to a subspecialist, or undergo additional unnecessary testing, and some will even be treated with chemotherapeutic or immunosuppressive agents, all because of our choice in testing.
The importance of specificity in allergic disease.
Tests that optimize specificity are not only used to minimize the risk of false positives, as in the previous rheumatoid arthritis example, but focusing on specificity allows us to tailor the management and treatment of our patients using assays with high specificity for allergen sensitization allows patients to be better categorized into various groups. For example, those that are potentially at high risk for life-threatening reactions requiring epinephrine administration, patients who have moderate to mild oral or pharyngeal symptoms, and those who are actually allergen tolerant despite sensitization. Let's look at this in more detail with Dr. Hernandez Trujillo, using peanut allergy as an example.
Dr. Vivian Hernandez Trujillo is Associate Clinical Professor of Pediatrics at Herbert Wertheim School of Medicine, Florida International University.
Hi, I'm Dr. Vivian Hernandez Trujillo. Peanut allergy affects approximately 9% of the general population based on positive skin testing. It's important to remember that this sensitization does not equal clinical allergy, which only affects 1% of the population, including those with oral pharyngeal symptoms and life-threatening anaphylaxis. Sensitive tests such as skin prick testing or in vitro testing with whole peanut extract detect the majority of patients with potential peanut allergy. However, because of their poor specificity, these tests do not allow us to differentiate which of these sensitized patients will have severe disease compared with the majority of patients who will develop mild or no symptoms. In fact, nearly half of those patients positive on skin prick testing with skin wheals greater than 8 millimeters had a negative food challenge and were peanut tolerant. Therefore, highly specific tests, such as in vitro component testing, should be considered to evaluate specific antigenic proteins or components within the peanut. For example, positivity for heat-stable storage proteins, such as ARA-H1, 2, or 3, are associated with clinically relevant allergic reactions, whereas isolated positivity for ARA-H8, a labile protein homologous to proteins found in birch and related tree pollen, signify a low risk of allergic reaction, despite positivity on whole peanut extract testing. Without a clear-cut clinical history, patients that are positive by the sensitive, but not specific, whole peanut extract testing could all be labeled potentially high risk for a severe allergic reaction. Since we cannot accurately predict which patients are clinically allergic, patients will often need an oral food challenge to distinguish those who could safely tolerate peanut ingestion from those who need to carry an epinephrine auto-injector. For this reason, component testing can help the clinician in the diagnosis of patients with suspected peanut allergy.
Summary.
It's important to note that no single laboratory test should be used in isolation to make a diagnosis or treatment plan. However, when trying to rule in or confirm a diagnosis, we should always consider tests which optimize specificity and/or positive predictive value, not only to help determine the appropriate treatment strategies, but to minimize false positives and the resulting clinical consequences. Remember, falsely diagnosing someone with a cancer syndrome or an incurable autoimmune disease based on an inappropriate laboratory test will have significant emotional, psychological, and usually financial costs for everyone concerned, including the physician.
Thank you for watching The Next Step, a diagnostic testing series. For more information or to watch additional videos, please visit our website at thermoscientific.com/Fadia.